Welcome to the next case series, or the next two cases, dealing with anticoagulation and anticoagulation in a complex patient. And I will start with one case, and then we will have Professor Widimsky with another case. I think I do as I did. I go straight on the case. This is a woman. She is born in 1941. She has a history of atherosclerotic disease. She is a previous smoker. She has hypertension and claudication. She performed a PTA on her right leg in 2011. She had an ST elevation myocardial infarction in 1994 with a post-MI heart failure and reduced ejection fraction that also resulted in CABG in 1994, and more recently she received a pacemaker for her heart failure, a CRT-D. She has permanent atrial fibrillation, and the history today, when I met her first, was in 2015. No complaints, heart failure, New York Heart Class 2, office blood pressure clearly elevated around 170 to 180 systolic, stable renal failure, CKD3B, with a current of R of 45. She was on multiple drugs for her blood pressure, and as you realize, she has what we call treatment-resistant hypertension, and she was not tolerant to alpha blockers. So, first question would be then, having this woman in front of you, what is the preferred treatment concerning anticoagulant, antiplatelet therapy? We could either choose antiplatelet therapy, whether that's single or double antiplatelet therapy, aspirin and or clopidogrel. We could choose warfarin, NOAC, or oral anticoagulant treatment plus antiplatelets. Any of you favoring alternative A, antiplatelets only? No. Would anybody give her warfarin? That means you would give her a NOAC. And would you combine the NOAC with an antiplatelet drug? Yes, some of you. The answer is quite easy. CABG in 1994, atrial fibrillation in 1994. We didn't have NOACs then, and certainly not in patients with renal failure. So she was put on warfarin then, and Dario Fo said that if you're on a bicycle, don't jump off it if you're going downhill. So if warfarin works, if the patient is happy, she's well controlled, no new complications, keep the therapy. So she was put on warfarin only, and warfarin is a good secondary prevention therapy after myocardial infarction. Don't forget that warfarin is much better than placebo and comparable to aspirin. Almost 2 years later, she still felt well, minor complaints, still New York Heart Class 2, office blood pressure slightly higher, as you see, 185/82. We performed an ABPM showing that she has persistent, clearly very elevated blood pressures. The problem now is that GFR declined. It's now GFR of 21. So she has a decline in renal function, an increase in blood pressure. She urgently needs her blood pressure to be controlled, both because of the kidneys and because of her heart failure. And the question is then, what do we do now? And a simple question, I don't think the answer is that easy. A simple question to you is the current risk with an oral anticoagulant for major bleeding, is that risk for bleeding greater than the benefit for preventing thromboembolism? Or is it actually so that the benefit of the oral anticoagulant is greater than the risk for bleeding? Who thinks that the risk with oral anticoagulants is greater? A. So all of you think that the benefit with oral anticoagulants is greater? Sorry? Well, you have the blood pressure here. The blood pressure is on average 178/86. And you can tell me how to control the blood pressure, but I didn't manage to control it better. And I think we don't know the answer because there are no studies. We have absolutely no idea. But we know the higher the blood pressure, the greater the risk for bleeding. You don't have to be a physician to understand that. The question is, when is blood pressure high enough? And if you ask people working with arrhythmias, they certainly don't bother about the blood pressure. If you ask us talking about blood pressure, we are more bothered about the blood pressure and the bleeding risks. But if we look into the guidelines, and the guidelines have a class 2A recommendation with a level B, they say that if you have a marked blood pressure elevation of 180 or 100 or higher, the aim should be to lower blood pressure. That is the recommendation. But also they say that patients should make an informed decision that they can accept that the stroke protection will be associated with a higher bleeding risk. So I think the jury is open. We don't know really which blood pressure is then exceeding the benefit of anticoagulant. But certainly this is a problem for this patient. So, as I said, the pressure is a problem. We performed the duplex investigation of renal arteries. Difficult to get good images, and we went on with the DT angiography. Obviously, this is a very high-risk patient for renal artery stenosis because of coronary artery disease and peripheral artery disease. She had extensive calcifications in the aorta. She had a severe stenosis on her right kidney, and she had a subtotal occlusion on the left kidney. So, should we go on with medical treatment of her bilateral renal artery stenosis? Because studies have not shown that there is benefit of treating surgically, or should we go on with PTRA? And if so, which of the kidneys? Or should we perform renal denervation? Anybody voting for A? Would you suggest to go on with dilatation, PTRA? Both? Left, right? Okay. And renal denervation? No. Again, studies say that medical treatment is probably as good if you don't have an acute renal failure, which she may have soon, but not yet, or whether you have an uncontrolled blood pressure and you think this is the reason. PTRA, yes. Left kidney is smaller. That's probably where the renin comes from. On the other hand, it's better to save the other kidney, which may be more well-functioning for the future. The risk to do both at the time, yes, if something goes wrong, that's not very good for her because then she'll be in dialysis. On the other hand, doing 2 sessions with renal failure and contrast is not ideal. We did renal denervation because you do that at the same time, and it's much easier to do before than after stenting. And we also did PTRA on both sides with stents on both sides. So now she has 2 stents in her renal arteries. What is then the preferred treatment for anticoagulant therapy? Should we continue with antiplatelet therapy? No, you didn't go through that. Should we continue with warfarin? Should we continue with NOAC? Or should we combine an oral anticoagulant with an antiplatelet drug? Anybody for B? One with B. Anybody for C? And for D? The argument for B would probably be with a very low renal function. It has been suggested that warfarin is better to monitor. It's easier to monitor, and you can adjust the values better. Although we have now data on apixaban in CKD 4, 5, and even in dialysis, and it seems to be even better. So today, perhaps apixaban would be a good alternative. And an antiplatelet drug, because of the stents, is probably reasonable, although it's not as important as it is in smaller vessels because of the large blood flow, and there is a relatively low risk actually for thrombosis. So I think the D would be the best. Again, we maintained warfarin because she was happy on that, and that worked well. Also, that was an excuse for her to go to the hospital every 4 weeks to have a contact, which is quite good because we could check her blood pressure. And then for the future then, if she has a recurrent angina and we have to do a PCI, what do we do then? And if she progresses to dialysis, should we continue with warfarin with the risk of calcium deposits in the vessels, or should we move to apixaban? And what happens if she has a TIA? These are open questions. I don't have the answers. Nobody has the answer. But I think we should do some educated guesses when we have the patient in front of us, and that is as far as we get. Any comments? Please. Speak up.
Which was the mechanism of lowering blood pressure? Renal reperfusion or renal denervation? We cannot. If you do both, we don't know which of the two was good.
Renal denervation is working. I mean, it is a mechanism that works. In my view, it works best in patients who have mild hypertension and no structural changes, and it doesn't work well if you have calcified concrete vessels because they cannot dilate. So this is not the dream patient to do renal denervation on. On the other hand, if you're in with a catheter in your renal arteries, if you have the option to do renal denervation, which is a safe procedure, why don't do it at the same time? Because you cannot easily do denervation after placing a stent, and you have the load of contrast media and so on. So that's why we did both at the same time. But scientifically, of course, we should first have done renal denervation, which according to studies would have reduced blood pressure by 10 millimeters of mercury, perhaps, which is not enough. But the main issue here was also to save the kidneys from acute renal failure in the future. I don't have the answer. But my guess would be the renal artery stenosis. I think we have to move on, right?
Thank you. May I have my slides? Thank you. My case will be much more simple, as you will see. So this is the patient history. In the respect of time, I will be very brief. So the important thing is that there is a strong positive family history for coronary artery disease and hypercholesterolemia. And then there is 11 years history of paroxysmal atrial fibrillation. And treatment was initially beta blockers, then flecainide with very good reaction to flecainide, and atorvastatin and rivaroxaban. And there is normal finding on echocardiography, including normal left atrial size and normal left ventricular function. And the patient is doing active sport. And interestingly, on May 8 last year, he was exercising on a mountain bike without any symptoms. And next day, he suffered unstable angina pectoris, underwent immediately coronary angiography, and there were 2 lesions and successful stenting with drug-eluting stent Xience. So the diagnostic summary, it's quite simple case, coronary artery disease with acute coronary syndrome in May 2018, treated with 2 drug-eluting stents, normal left ventricular function, and 11 years history of paroxysmal atrial fibrillation, sinus rhythm kept with flecainide, normal blood pressure, and hypercholesterolemia very well compensated with atorvastatin. So I have 4 questions for you. What antithrombotic treatment do you suggest for paroxysmal atrial fibrillation during those 10 years before coronary artery disease was known, when the patient was completely asymptomatic? So CHA2DS2-VASc score in that time was 0. No antithrombotic treatment, 1. Who will be in favor of no antithrombotics? Okay, thank you. The second option is long-term aspirin for primary prevention, more for coronary artery disease than for AFib because of family history and hypercholesterolemia. Who would go for primary aspirin? Nobody? Long-term warfarin? Nobody? Long-term NOAC? And NOAC as pill in the pocket during paroxysm? Nobody? Okay. Next question. What antithrombotic treatment do you suggest for the first year after acute coronary syndrome? So I remind you, the patient has 11 years history of atrial fibrillation, paroxysms, and then in May last year, acute coronary syndrome and 2 drug-eluting stents. So what antithrombotic treatment you suggest in this situation for the first year after acute coronary syndrome? And the patient has CHA2DS2-VASc 2, there is mistake, CHA2DS2-VASc 2 because achieved age 65 and has coronary artery disease. First option, dual antiplatelet treatment. Who will go for only dual antiplatelet treatment? Nobody? Second option, dual antiplatelet treatment with ad hoc NOAC, pill in the pocket during paroxysms. 1? 2? Okay. Third possibility, triple therapy for the first month and continue then with aspirin and warfarin for long term. 1? Yes. Number 4, triple therapy for the first month and continue with aspirin and NOAC in long term. Majority, thank you. And last option, other treatment. So maybe one possibility is triple therapy for the first month and ticagrelor and NOAC for long term. Nobody. Okay, thanks. So majority was for option 4. Question 3. What antithrombotic treatment do you suggest after the first year? So for long-term secondary prevention after more than 1 year since acute coronary syndrome. And the patient has the CHA2DS2-VASc score 2 and 2 stents implanted in coronary arteries. First, antiplatelet monotherapy with any of the antiplatelet agents. One? Just one? Okay. Different than with the previous group. Anticoagulant monotherapy. Majority, yes. Dual antiplatelet treatment based on the Pegasus trial design. No. Aspirin and low-dose rivaroxaban based on COMPASS trial data. 1, 2, 3, 4, 5. Okay, thank you. Aspirin and warfarin. Nobody? And aspirin monotherapy with only ad hoc NOAC pill in the pocket because the atrial paroxysms are quite rare, 2, 3 per year. Nobody? Okay, thank you. And the last question. The last question is, what treatment you suggest for this patient with CHA2DS2-VASc score 2 and history of 11 years of paroxysms of atrial fibrillation, but the paroxysms are symptomatic but not frequent. And there is a good response to flecainide. Every paroxysm is treated within few hours with flecainide pill in the pocket. You should, but the patient has now coronary artery disease. This is important. Continue chronic flecainide. Who will continue chronic flecainide if it is successful during 11 years? Nobody? Who will stop chronic flecainide due to the presence of coronary artery disease, but keep it as pill in the pocket treatment for the paroxysms? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 15 maybe. Who will recommend radiofrequency ablation of pulmonary veins? 3, 4, 5. Again, difference with the previous group. Will somebody recommend left atrial appendage occluder? No? And some other proposal? Yes, which? What?
I would try hard with a beta blocker first line. If that didn't work, you could go for an ablation, or I'd only use flecainide if I didn't see any scar on MRI, I think. That might be an option if you really felt that it suited the patient well and they were happy to take that.
Thank you. Any other comment to this last question? And my last slide, the patient is myself.